So continuing in our discussion of application, the next tool we're going to look at is this idea of clinical prediction rules and how we can use clinical prediction rules to help us make decisions. So our objectives and key points, we want to understand what these clinical prediction rules are, also then understand how they are created, and then finally understand how we can go about utilizing them. So a clinical prediction rule is basically a decision-making tool set. So a decision-making process that's similar to what we've been describing regarding application and appraisal occurs and then comes with a specific outcome that is designed to help clinicians determine specific inclusion criteria for their participants. So the idea is and the easiest way I like to think of these is that clinical prediction rules are diagnostic in nature. And I mean that from the standpoint that yes, there are diagnostic clinical prediction rules. But what they do is they create a variety of variables that can be combined to diagnose whether or not somebody should or should not be in a specific group. And that group can be a group to determine whether or not an intervention might be successful. So there are like clinical prediction rules to describe things like whether or not spinal manipulation would lead to positive outcomes. There are also prognostic clinical prediction rules that basically describe the outcome for patients within a certain condition, whether or not they fall into the criteria needed in order to expect a certain outcome, or then the diagnostic ones, which are just purely whether or not they have the condition or not. And so when we look at these clinical prediction rules, they have a three-step process and how to go about doing it. And the first one is basically the development of this process. And this includes a variety of different ways. And this is basically the foundational process with the creation of the clinical prediction rule. But it starts by identifying a certain number of predictor variables of interest. And so you're going to analyze individuals for these different variables and then try to determine whether or not these fall into the group and see which of these variables are predictive. And so you take and measure these individuals on a large or on all of the variables. And so in this example here, describing a potential clinical prediction rule for medial epicondylitis, trying to determine whether or not individuals have that, you can see they have several clinical predictor variables. And these variables are all things that have the possibility of contributing to a diagnosis of medial epicondylitis. So this is similar to when we were talking last time about the diagnostic accuracy, and we're including specific tests. This is now combining multiple of those tests and then rerunning the statistics. Is basically the same way to look at it. The more variables you need, the more subjects you need during this portion of creating the clinical prediction rule. And so you can see they say about 10 to 15 subjects for every variable. So the sample size needs to be between 70 and 105 for this aspect. You then need a reference criterion. Basically, same thing as in that diagnostic. Say you need some way to determine whether or not these individuals fall into the classification that we're trying to classify them in or not, whether that is whether or not they have the condition, end up with a certain outcome in prognostic CPRs, or in the treatment outcome where they might have a positive result based on a certain reference criterion. In this case, we're just going to look at MRIs. They do their stats as far as how they do that, and then they end up finding a subset of the original subset of the original predictor variables. And so this idea that if you have pain with resisted wrist flexion, you have point tenderness over the medial epicondyle, decreased grip strength, and an absence of tingling over the ulnar nerve distribution, that chances are good that you would have this condition. From there, you need to go into the validation of the study. And so these are always two separate studies and need to be done separately. They could possibly be combined into a single paper, but that's a lower level of validation is what we'll see. There are 4 levels of validation. So this is an idea that once we have identified the predictive variables or the categories that we need to categorize people in order to see whether or not they're going to fit into this prediction rule, we need to apply that in a different setting or a different patient sample. And so we can confirm that this goes through. And so the 4 levels of validation you can see are listed there. The lowest level is simply trying to confirm or replicate the clinical prediction rule. So the idea here is either the same group or even possibly a different group just basically does the exact same thing with the exact same type of people and get similar findings. So this idea that it's reproducible. But we then need to look at the stability of the clinical prediction rule. And so this now gets into the idea of prospectively studying individuals. Oftentimes these validation studies or these clinical prediction rules are created on individuals that we already know have the condition. So we need to prospectively look at them on whether or not it's in fact truly predictive. And then level 2 is determining with a variety of patients. And then level 1 validation actually involves changing outcomes in clinical practice. And so that is the third step, this idea of an impact analysis. Does the clinical prediction rule in fact change the way people do things? If a good clinical prediction rule, right, leads to change, oftentimes it may be redefined as a clinical decision rule, just basically meaning that it's reached the highest levels of validation and has started to change behaviors. And so the idea here is a good clinical prediction rule or clinical decision rule, the same way that good use of evidence-based medicine would change the way we practice. And so the idea here is if we're using evidence, and that evidence indicates that a certain group would respond well to a specific treatment, that's the same as the evidence-based practice aspect that we've talked about. And so we should start to implement those decision rules within our normal practice. And so as we go through, it's always important to continue to appraise this. I don't want to skip over that, but we've talked about that in depth. But then you start to apply these decision rules within your clinical practice. So as you go through this evidence-based practice component, it's the same as the clinical prediction rules. You've created your question or your ideas in or in a clinical prediction rule, the variables of interest. You've searched and refined them, and you've came up with the results then and appraised those results to come up with what your best thought is for the intervention, and then you're going to move to apply that intervention. And so when we think of clinical prediction rules, it's simply the easiest way in the lowest level of lowest level of effort for clinicians to specifically address different content. So like systematic reviews and meta-analysis are nice, but they still require some more interpretation, whereas the clinical prediction rules or clinical decision rules very much say, you know, follow this sort of script and this is an expected outcome. And that's what we're going for anyway with the evidence-based practice model. you're looking for. If you have a situation that's similar to the research that you found, you can expect similar outcomes. And so how you go about doing that will be the topic of future lessons when we look at disablement models and look at how we can go about then taking the analyzation we have and creating the decision in order to apply it.